Dr. Gadre, Dr. Kumbar, and friends. It's indeed a pleasure to be here. And as I was talking to Dr. Gadre earlier, the need for crosstalk. We are in a learning mechanism or the methods with which we impart education these days is, if there is a huge amount of wealth of information, data, then we break it into smaller and smaller bits. And the purpose, everybody very strongly says that the purpose of breaking data into smaller and smaller bits is the best way of understanding it. I reinterpret that by saying that we are unable to understand the data when it is big. So it is for our frailties, our convenience, that we break it into bits and pieces which are then understandable to us. But finally, having understood that bit, we forget which was the bigger component. So while looking at a big forest, difficult to fathom, difficult to understand, and what we tend to do is concentrate, get into a smaller and smaller bit and understand only one tree, and then assume that this tree is your world. Now, this kind of smaller and smaller bits is what has happened today, that there are individuals who are doing biochemistry, there are individuals who are doing some other kind of structural chemistry, there are some individuals doing some different kind of physics, quantum physics, nuclear physics, and then different kind of physics has sub-branches within it. And we have forgotten that in nature, there are no such divisions. All this is in a symphony, excellent togetherness, which creates a bigger design. And that's the reason why I have decided to talk on crosstalk. We, in fact, for our own understanding, divide our own subject into smaller and smaller bits so that we understand. But finally, we have forgotten that what was the primary purpose, what was the original reason why we broke it down for understanding this bit, but all put together, it should make a bigger sense. That's the reason why we are into what we are doing today. So cancer has also gone through the same kind of activity. And while we understand cancer, we have forgotten that there is physics that we use, there is chemistry that we use, there is a biochemistry and biophysics that we use in that. And finally, all that affects our system, our own bodies. Let's look at some numbers first. I am very fond of numbers, and there will be lots of numbers in my talk. So, cancer in India versus cancer globally. How different are we? And lots of things can be learned out of that too. So here are some numbers. If you look at US or UK, the numbers are every year, for every 1 lakh population, there are about 300 cancer patients. This could vary from 280, 290 to 350 in some parts, but around 300 is a number that they have. In urban India, this number is 100. So we are 1/3. We are much better off. In semi-urban India, say if I were to look at Pune, Miraj, and any of the mid-sized towns, Pune is no more a mid-sized town, it's a metropolitan city today. So you have already inched towards 100 per 100,000. But otherwise, it would have been somewhere close to, Pune would be somewhere close to 100 by now, whereas smaller mid-sized towns will be between 60 and 75, and rural India is between 40 and 50. You might say that there are lots of missed cases. There are lots of cases that are happening in rural India. We may not be detecting them, and since we are not picking it up, that's why your numbers are small. But that's not the case. There are about 4 or 5 registries, rural cancer registries across India, and we do a house-to-house survey on an annual basis, covering more than 1 million population. And the numbers have been constant. They are between 40 and 50, and they've remained static for quite some time. To the extent that breast cancer in this population is so low that it's somewhere close to 8 or 9, and this is the only population where the number has remained static at 8 and 9. So Bill Melinda Gates Foundation put in somewhere to the tune of about more than $1.5 million in a town close from here called Barshi to understand why breast cancer is so low in that region, and can they export something to United States so that their breast cancer incidence reduces, because in United States the numbers are close to 120 per 100,000, whereas in Barshi it has remained 8 to 9 per 100,000 population. We do have a pocket in India, northeastern India, where the numbers are high in some pockets, and we are quite close to the western population, and we are studying why that is happening. But you must have noted that about 20 years ago, the number of people who spoke about cancer versus today, the number is quite high today, and we perceive that cancer is much bigger today, and that perception is not actually correct, because this number of 100 in metropolitan has remained 100 for the last 15 years. The number which is 60 to 75 in semi-urban has remained that for last 20-25 years, and the rural numbers have also remained static for 20-25 years. So we are not rising, but what happens is, read the last sentence. Every decade in census we get to know that some bit of rural population has become semi-urban and a lot of semi-urban has become urban. So there is a transition of individuals from this population to that population and that population to that population. So the absolute numbers would rise over a period of time, and our population is also rising. We are not stopping our reproductive abilities at all. So which gives us that there would be a lot more people in India, and that also will give us more numbers. In general, I will try and allude as to where all you, maybe student of physics, engineering, students of chemistry and biology could give inputs on that. So we already have about a third of what US or UK has in our cities. Now what are the kinds of cancers? If you look at a great majority, all these three put together constitute about 70% of our cancer. So 70% of our cancers are preventable. Now prevention, very easily possible. We take care of tobacco. Tobacco accounts for about 40% of cancers in India. So tobacco accounts for about 40% of cancers in India, and infections account for another about 15% of cancers. But as we get into urbanization, wherein running water is available, human hygiene has improved quite a bit, that itself reduces many cancers. And one of the best example is cervical cancer in women. That has gone down remarkably. In Barshi, it continues to be about 30 per 100,000. In Pune, it has come to about 12 per 100,000. And in Mumbai, for quite some time, it has come to 8 per 100,000. Now, this 8 compared to United States, where it is 7.5. So we are no different as far as personal hygiene is concerned in parts of India. But in rural India, where men take bath on a common well, putting on their clothes still on while having bath, the personal hygiene is going to be poor. And the possibility of these infections being transmitted to women are pretty high. So uterine cervical cancer continues to be high in rural Indian pockets. Another big scourge is obesity, which is a urban phenomenon. Increasing weight. A great number of if you go to schools today, almost all children are pretty roly-poly. You know, and yet majority of the women, mothers, if you talk to, and I do go to many schools to talk about cancer awareness, and I find that all children are very, very paunchy and big ones. At the end of the talk, when I talk to parents, there is not a single mother who doesn't say that the child doesn't eat. And I wonder, if child doesn't eat, where does the fat come from? But anyway, there is some reason to believe that we need to take care of obesity, which is an urban phenomenon, and obesity accounts for 13 different kinds of cancers. So 13 different cancers will reduce remarkably if we don't put on weight. So I'm sure there are people who are here, maybe from, I don't know whether there are any from engineering background, but one could think of what kind of solutions one could think of that if you are working in a workplace, and while working, if you have a chair that has a small bicycle. So you are working, but you are working your legs continuously. I found this very nice chair on Zurich airport, and the coffee shop had all the chairs that had a bicycle at the bottom. So if you are having a cup of coffee, obviously that should be without sugar, you would continue to do some exercises. So while you are doing something, could you exercise yourself? Another area which one could easily work on is the travelators that we keep on getting at the airport. Now the travelators allow people to walk if they want to. If they don't want to walk, they will stand, yet will go at the other end. But a travelator that is moving at say 5 kilometers an hour is a speed at which we walk on the footpath. One could easily step onto it and start walking on it. If we walk on that travelator, which is moving at a 5 kilometer per hour, you will walk at 10 kilometers an hour, because you are walking at 5 kilometers, the travelator is moving at 5 kilometers, you will walk at 10 kilometers. So let there be two travelators, one by the side of the other, and the other travelator moving at 10 kilometers an hour. You step onto that, you start walking on it. You are walking at 15 kilometers an hour. I don't think in Pune, in peak hours, one can drive at that speed. It is an impossibility. For a kilometer, you would take about 25 minutes during peak hours. So if in business district, if we have this kind of travelators, or even long distance, I keep on giving this example of from one end, say Warsaw in Mumbai versus Gateway of India, the distance through sea, wherein there is a sea link that is happening, one part is already happened, or the coastal road is that is happening, the distance would be about 14 kilometers. Imagine I start walking from Warsaw, and in an hour's time, I would be at Gateway of India. Today, sitting in a bus or in a train, the travel time is about an hour 45 minutes, sitting at one place. In an hour, I would not produce any kind of pollution, and breathing a fresh sea wind continuously. Imagine if the whole Pune is to walk, or whole of Mumbai was to walk from one end to the other to go to work. While we are doing this activity, I'm sure we would be a lot healthier, and I won't have the reason to practice medicine at all if cancer reduces remarkably. And reducing obesity is not only going to reduce cancer, but it is also going to reduce diabetes and high blood pressure. So stroke as well as heart attacks, all of them will reduce remarkably if we were to tackle obesity to some extent. So some kind of a solution, either doing exercise or creating a machine that will allow you to exercise while you are doing something else. Because it's damn difficult. If you ask somebody, are you willing to go and exercise in a gym? Some of them will, but those are individuals who are already thin. They are not the ones who need exercise. So if you ask somebody else, all of them are extremely busy. So busy that they can't find time to do exercises. We then get on to, from there on, the logic is that if I were to treat small cancers, the cure rates are close to 80%. 80% of them may survive and will have a normal lifespan. The same patient, if it were to be detected with cancer, when the size is much larger, and I would say, for example, call it T4, the cure rate will be 20%. So why can't I have all of them diagnosed at T1? And then all of them will have great survival. We would conquer cancer without any problems. Now that's a very simple logic, should work. Unfortunately, in biological systems, you need to run experiment to actually see that it works. And what has happened, that it has succeeded greatly for oral cancer, that you pick up somebody who is chewing tobacco, examine his mouth once a year. That individual himself can examine, or herself can examine, and look for any ulcers, white patch, red patch, and seek medical advice if there is something. And that kind of activity itself reduces the death rate related to oral cancer. We have proved it beyond doubt. Uterine cervical cancer with pap smear or visual inspection, again, cure rates are easily possible to a great extent. Breast cancer, when the similar trials were done, great amount of reduction in tumor size by doing screening, but reduction in deaths only in women above 50. Women below 50, there was no reduction in death. So when it comes to biological systems, there is something else that is functional and we don't know how to do it. So is there some other way? There are many other places where things have failed miserably. Look at prostate cancer. There is an excellent biomarker in blood called PSA, prostate specific antigen. Now, if we were to pick it up, a great number of prostate cancers will be picked up when they are T1 size, small size prostate cancers. The same thing was done, but at the end of 15 years of follow-up, we find that there is no difference in death whether it was done or not done. In fact, the death rate was higher when it was done with PSA estimation. So it might appear logical, but it doesn't always come true, or our biomarkers are failing. So we need to look at the same failure we have met in lung cancer and breast cancer below 50 years of age, that there is in fact an excess death. You do an investigation, pick up early tumor and more people die of that cancer. So no part of the world offers screening for these cancers except when you have yourself found a method of estimating PSA. Then you want to sell something. That's a completely mercantile reason for you to sell something. It doesn't matter whether somebody lives or doesn't live. That's not the purpose, but there is a huge amount of overdiagnosis. That means there is a difference between somebody coming to me with a symptom or with some problem versus me going to all the population. I just now mentioned that if only 100 people get out of 100,000, that means a great number don't have cancer. In fact, the majority don't have cancer. We are looking at approximately 99,999 individuals, 980 individuals who will not have breast cancer, any cancer at all. But if I were to screen, suddenly the cancer starts rising. And a lot of cancer that has risen in United States and UK is because of their act of observation. More they look for, more cancers will they get in return. And that doesn't necessarily mean that the lives are saved, because the number of people dying of cancer in that country are higher compared to what our country has. So this problem of overdiagnosis there, well, where have we failed then? We need to understand where have we failed. There are lots of people who today talk of liquid biopsy. There are lots of labs here in Pune with the kind of bioinformatics background that is available in Pune. There are lots of labs that offer that we'll do a blood test and we can pick up an abnormal cancer cell. Now, the problem there with liquid biopsy is this is a technology. Again, somebody from your end who is doing biophysics will understand that the precision with which I can now look at a cell that is circulating has improved remarkably compared to what it was possible 10 years ago because of the technology. Now, technology is available, I can look for cells. I look for cell, I get some cells. Where has it come from? Do I know where the cancer is? No, I don't know. So I run a test, then I ask for a CT scan. Whole body CT scan I do or whole body MRI I do. And if I don't find, then what do I say? You don't have cancer at the moment, but you will get someday. So these tests have slowly become a bit of astrology. We need some solid evidence to say that there is something coming up. What I'm trying to tell you is that there should be something that is tested robustly, gives an evidence which clearly says that lives are saved by performing the test, and then such tests should be offered to everybody. So this is what the president of ASCO is one of the major societies globally in United States, but globally functional, that there may be multitudes of things that I may have a circulating tumor cell or circulating DNA. The rate at which technology is getting into precision, that we get huge amount of data. I ask one question and I get so much of data that finally I need to understand the question that I asked, has it been answered, or I am thrown back at, something is thrown back at me with 100 more questions rather than answering one question that I have asked for. So we need to take this with a pinch of salt that there may be technology, but that's only information. Technology is giving information. Unless you ask a proper question and confirm that the answer is what you expect or otherwise, then you can either uphold that technology or dump it. But we need to be very clear in mind as to is that possible or not. But presently, whatever biopsies we performed or imaging that we performed can't be replaced by any of these newer technologies. So technology is there, but we need to sip it properly to understand as to whether this is useful at all. Now in general, again, the same gentleman talking about if you have a test which is bad, then it is worse. It is worse than giving a drug, because you are then looking at a healthy individual being stamped with cancer or stamped with a possibility of cancer and leave him in society for years to come. That's not the reason why we are here. We are here to reduce disease, not to create disease in society. So what are our failures? I want to detect killer cancer cells. I want to detect a killer cancer. I don't want to detect cancers which may be there lurking in tissues. Lots of cells change their patterns, change their phenotype to appear that they are cancerous, but they don't have all the phenotypes of cancer to kill the host. It's quite similar to Bhurtezor. You know, these small felonies that are performed, we are not looking at small felonies, we are looking at somebody who will pick up an AK-47 and fire 100 people down, kill 100 people down. That is what we are looking for. But while looking for AK-47, we get so many other small thieves that the number of cancers start rising. And that is a problem. So I would urge those who are doing their biophysics, biochemistry, look for a marker that will pick up killer cancer, not all cancers. To give an example, if 1,000 women walking on the streets of Pune without any diagnosis of cancer, if they were to be examined by a trained female health worker or a trained gynecologist for their clinical examination of breast, I am looking at women between 35 and 75 years of age. In such 1,000 women, a clinical breast examination might pick up one cancer, which was not diagnosed earlier. The same 1,000 women undergoing a mammography will increase this number from 1 to 2. I then use MRI, more precision technology. That number 2 will become 4. God forbid nothing should happen to these women, but if I were to look at women dying of vehicular accident between the same age group, 35 to 75, and if I were to perform autopsy studies, post-mortem studies to understand whether the breast has cancer or not, and to my surprise, I find that in such 1,000 women, there are at least about 200 cancers. So how much are we picking? We are picking only 1, 2, 4, upper limit 6. We are missing out on those rest of 194, which are lurking in population, but they will never surface. That means our human body has capability, even if some cells turn abnormal, they are not allowed to manifest themselves to threaten the host. Now we should not allow our bodily defenses not to be functional like this. If we keep on picking up these cancers, we will get cancers, and those cancers will be treated. And then finally, if I were to treat only cancers that are lurking in the population without ever manifested, all those women will live for next 20 years. Saying that hey, I have conquered cancer, but in the first place, that cancer would have never manifested. You understand what it is? That unnecessary procedures can give rise to unnecessary diagnosis, unnecessary stamp. and that unnecessary stamp will allow any of the doctors to become extremely popular. That you go to this doctor and you never die. No, that's what I'm selling. I'm selling immortality. As a doctor, I don't want patients to die. So the purpose of my presence is to sell immortality. So that's what I'm doing at the moment. But my failure is that I cannot give more than 20% cure rate for somebody who is presented to me late. Instead of me saying that I have that failure, I tell that patient, you have come late. You understand? That I have transferred my guilt onto that patient, saying that it's not my fault, you have come late, that's why I can't cure you. But primarily it is my problem, and we need to find solutions to that. Let's look at some of the solutions, and let's look at some of the older solutions. There are some graphs here. These are survival graphs. That means, say for example, the top graph shows those who have taken a medicine, the lower graph shows those who have not taken medicine in low risk population. The top graph, high risk population who has taken medicine, and high risk population who have not taken medicine. So between taking medicine or not taking medicine, approximately 5 to 12% reduction in deaths. So 5 to 12% reduction. This is using either chemotherapy or stopping ovaries. Whatever that is, that's not important to understand. But simple therapies, these therapies would cost somewhere to the tune of about 300 to 500 rupees. Ovarian ablation will not cost anything at all. It's a small surgery which takes, it's a daycare surgery. Similarly, another medicine called tamoxifen, a tablet, a packet of 10 tablets cost about 15 rupees, and you need to take 1 tablet a day. Now if taken for 5 years, the end result is that there is a reduction in death from 45% to 33% by taking the medicine. That cheaper medicine giving you a difference which is 10%, 12%, 15% reduction in death. Let's go to these are the results of yesteryears. About 30 years, 25 years ago, these trials were done, and huge amount of benefit by least side effects and least damage to the pocket. Look at what happens now. Today, we have chemotherapies, or we have some other different agents being utilized, taxanes and other things. The cost is about 30,000 to 100,000 rupees. The cost of medicine here is 30,000 to 250,000 rupees. For that kind of cost, what is the reduction in lives? The reduction in death? The reduction in death is 2%, 2.5%. What has changed over a period of time is, for bag full of money, you have that kind of differences. We need to look at it that can we utilize some chemical moieties that any of you are working on. You have a thought process, it could be serendipity, it could be a focused area that you are looking for. When I say serendipity, I am looking at, say for example, how does metastasis set in? Metastasis is a process by which cell leaves the primary tumor bearing area, goes somewhere else and settles there and starts replicating. That is a distant metastasis. And cancer can kill only when it metastasizes. So it is the metastatic disease that kills a patient, but that movement of cell is what is important. Now, can there be some drug that any of you are working on which will increase the adhesion between cells? Is that a possibility at all? When I say serendipity, I am looking at a pathologist looking at cervical smears. In women, scraping from the uterine cervix is looked upon under the microscope to find out whether there are any cancer cells, what we call pap smears. A pap test is done for diagnosis of cervical cancer. Now, if you look at that, then if you ask a pathologist that suddenly a pathologist from Guy's Hospital came up with a thing that there are some percentage of women wherein repeated test doesn't give any cells at all. The procedure is done appropriately once, repeated twice, repeated 3 times, but the cells just don't come. What does that mean? That the cell to cell adhesion is so strong that even your spatula, as it crosses against, as it abrades against the uterine cervix, no cell can be exfoliated from the surface. And what was found, that a great majority of these women were heroin addicts. So we are looking at cannabis. Cannabis induces huge amount of cell-to-cell adhesion. Cell-to-cell adhesion is so strong in cannabis I'm not asking you to take cannabis, please don't misunderstand. I'm just giving you an example as to what can serendipitously come onto your labs, and then investigations further to understand. So we are investigating, is there a possibility of utilizing this part of it without the addicting part of it, without the psychedelic part of that drug being so appealing. So there are so many things that can happen. Another drug which is hugely expensive, giving rise to a very teeny-weeny benefit. Look at, I mean, from your distance you can't even see that the graphs are separating out there, but graphs are separating. They are separating for 1.5%. 1.5% benefit for a single tablet to be taken for 5 years, and the cost of the tablet is approximately 350 rupees. 350 rupees every day for 5 years, that's huge amount of cost. Not many people will be able to afford it. The same thing true is for Herceptin. This takes the cake. The cost of this medicine, which gives you a difference of about 5%, is approximately 20 lakhs. I can't afford it. I don't think great majority of us will ever afford it. So we need to understand as to how best we can find out drugs, either repurposing drugs, existing drugs being taught a new trick, or getting a new drug which is simple enough without much of cost involved. So who benefits from treatment? If I go back to the graph, you will find that even if I don't take medicine, that many will live. Even if I take medicine, that many will die. And only that many patients will have a difference. Is there some way of me knowing who will be benefited like this? Then I will give only to these 5%. But today I am giving to all 100% of patients. So the only person that is benefited is the industry. We are not helping the patients at all. So we need to understand who benefits. Is there any way of finding out who benefits? And there are ways, there are tests that have come up, and any of your biophysics individual or biochemical individuals could work on what's there on the surface for me to understand, will this drug be useful at all? Say for example, using tamoxifen and finding out whether they are estrogen receptor positive. Since I'm giving an anti-estrogen treatment, it will be beneficial only if there is an estrogen receptor on that cell. If there is no receptor, the cell is probably using survival pathways which are distinct compared to estrogenic pathways. So such simple things can be utilized, and we can still get some better scores out of this. But in general, there are various things which may be useful, and today we are in the world of genomics. So we know hundreds of targets. I keep on doing a genomic analysis or analysis which looks at the expression of DNA, that is mRNA expression. So either RNA-seq or a DNA analysis to understand what is targetable in that tumor. So we run a study. This is the in thing today, and every industry is doing it. So a study was run wherein all the targets, I will look at the biopsy sample, look at all the targets and hit these targets with drugs. These drugs are phenomenally expensive, but I hit only that versus giving the general medicine without knowing whether the targets are there or not. So a general chemotherapy, which is today termed as a blunderbuss approach. So with a great aplomb, we looked at this study that something will come out of it. Unfortunately, having gone through all that, we find that finally one out of 423 patients that signed on it, only 194 had targetable genes available, and more importantly, finally having gone through all that, only 48 patients had genomic driven treatment, and how many had objective response? 9%. 91% did not have even objective response, leave alone eradicating disease, leave alone cure. That is far away. So we may have a fantastically good thought process, but we need finally to get into clinic to understand whether something is useful at all, or it's only a great logic that there is a receptor and I need to treat the receptor with some treatment. Similarly, there are molecular targets which are refractory, the very famous Shiva trial. Again, a negative study, targeted tumors. What I'm trying to drive home here is that there may be lots of patients finally being treated, a very small percentage gets treated, and the benefit out of it is close to zero. But there is a logic. There was a logic, and today a lot of patients still take treatment exactly based on this because it is appealing. My tumor is unique, and that uniqueness of my tumor I'm going to hit with some bullet that goes straight onto that tumor. Is there a possibility that I can do it? No, and the benefit is extremely small, and there is just no way. See, so many targets were found, so many targets were hit, and in spite of doing all this, we find that that's the survival figure. Whether giving or not giving, red or blue, there is hardly anything to choose. So there may be logic, but finally in a biological system we need to prove whether that logic is upheld or not upheld at all. And we have no way to say that there is any benefit at all. In today's world, personalized medicine is the key word. Everybody wants to use personalized medicine, being a little precious that I have something unique and that unique is being hit is something that everybody wants to try, but it doesn't give us exactly the same thing. And why does this happen? Every time a tumor cell divides, it produces new targets. So if there are 100 cells there, all are not dividing at the same time. 10 are dividing today, 10 are dividing tomorrow, and another 20 might be dividing 10 days down the line. Every division produces new targets. So even if I have a target that is expressed only in 10% of the patients or 10% of the cells, those 10% of the cells might die. But that doesn't mean the other cells will continue to be there. They will replace, they will repopulate all that dead tumor within no time, and with every division of repopulation, new targets will come up. So it's a smart cell that is beating us before we even think. So tumor heterogeneity is something that is killing us at this juncture in practicing what is termed as personalized medicine. So the conclusion of that was that there was a technology that gives huge amount of information, but is it useful in the clinic? So however, the simple view of directing therapy on the basis of genetic tumor markers is probably too simple and has failed miserably. The only way I can say that this was said a long time ago, that physician's belief in his treatment and the patient's faith in his physician exerts a mutually reinforcing effect, and the result is a powerful remedy which is almost guaranteed to produce an improvement and sometimes a cure. But that's a placebo effect as described. So one might have benefit out of it, but presently we are unable to cure. There is no way I can ever say that the failure that we have ever say that recurrent disease has been cured. Recurrent disease remains incurable in any part of the world, and Sushruta in his writings had written that recurrent disease then was also not curable. So what has changed? Sushruta's time and now, something that is there once record cannot be cured in any way. We need to understand how can we reduce our cure rates, reduce our recurrence rates so that we can improve our cure rates. Stage match survival has also not improved remarkably. I'm actually giving you a very pessimistic view of what's happening in the clinic, but that's the reality. Screening is successful in few cancers, but in great majority it has failed. We need to find newer solutions. I'll give you one or two examples quickly, and then we can get on to some question answers. I just now mentioned that 10% of the tumors might be expressing, tumor cells might be expressing some targets. The targeted molecule goes to that cell, gets attached to that cell, but has the capability of killing only 10% of those cells that are expressing. Those cells are also 10% in the tumor. Is there any way I can do something? Can I go to our quantum physics people? Get me a radioisotope. Here is a bullet that targetedly goes to the tumor. Can I increase the payload on top of this molecule. And if I can increase the payload, then the molecule which has the capability of going to tumor will carry this payload there and will blast off the whole of the surrounding area. So if one cell was to die, 10% of the cells were there expressing, these 10% of the cells will take up the molecule completely, and in the surrounding vicinity of each cell there will be a killing which will affect more than 2 to 3 centimeters of tumor. So is there any way that we can create such smart bombs? There are two areas where we are functioning at the moment with the help of physicists from BARC, the Bhabha Atomic Research Center, and we have used lutetium and few other yttrium, iodine 131, any of these to be tagged onto a molecule, and the end result is that what we could be achieving by giving 9 months of treatment could be achieved by giving only one injection. So reducing the duration of treatment, reducing the cost of treatment. No industry is going to do it. We need to do it. We need to convince our government that please give, your cost of medicine is going to reduce by 1/9. Instead of 9 months of treatment once every month, the patient will take only single treatment and will have the same cure rates as 9 months of treatment. Similarly, there are many other targeted agents which we are looking at, but essentially we are looking at somebody from physics allowing us to create a smart bomb which will not interfere with the ability of this molecule to meet the receptor which is there on the tumor, and also release the isotope which it is carrying on its back. So both those activities need to be done, and a lot of input from young minds like yourself would be of great use. Those who are doing chemistry, if they are into medicinal chemistry, I need to find a molecule which will stop invasion of the cell. A cell that has come in, killing or digesting the surrounding tissue so that it can invade into surrounding tissue, which is the biggest property of invasive cancer. Or cell-to-cell adhesion. I mentioned about cannabis. There is another drug, naturally occurring hormone called progesterone, that also increases cell-to-cell adhesion to a great extent. So there are ways and means of finding out what can work from chemistry side. Here are some pictures that are of tagged molecule. This is Herceptin, a drug that is used against HER2 positive. HER2 is a tumor expressing growth factor receptor that when positive the cell grows much faster, and if that is positive there is a targeted molecule called Herceptin. And I showed you the figure earlier that this molecule goes straight to the tumor, but its ability to kill is not very great. It kills, but it doesn't kill all the tumor cells. So the difference in survival is somewhere to the tune of about 5% to 8%. That is the kind of difference. But the cost of this drug is 20 lakhs of rupees, and we need to use it for 1 full year. Imagine if we were to have targeted, so we have tagged this molecule with lutetium and it reaches liver which was studded with tumor, and over a period of time the same molecule completely eradicates the same tumor which is there in liver. People who are doing physics could help us in 2-3 things. Here is a machine, an old machine, but machine made in such a way that if there is no electricity, it can work on UPS. It can work on a UPS and deliver radiation to the cancer patients. If I were to give radiation 5 days in a week versus 6 days in a week, my cure rate improves by 10%. Imagine if I have a machine which works only on electricity and half the time the machine is not working in a rural component of India, then how do I deliver 6 days a week treatment? If I were to give only 4 days treatment, instead of improving 10%, I'm going to have a detriment of 10%. So we need to look at what is required in our own country. If electricity is not available across, for some rural pockets we need a machine that will work on UPS. So this is a machine produced by physicists in Bark, and that works on UPS. It will work on electricity also, but if there is no electricity, it will work on UPS for 24 hours. So it is easily possible to treat patients without any problems. That's the kind of UPS on which it works, and it will sustain itself in spite of no electricity. Last time when we had the visitors from the IAEA, International Atomic Energy Agency, they have picked up our machine, and there are at least about 10 such machines that have gone to various parts of Africa and some of the parts of Orient. Vietnam has, Sri Lanka has, Bangladesh has, and there are at least 8 other countries in Africa that have our machine. That Mongolia has, thank you so much for that, Mongolia has the same machine, and these are countries wherein there are no radiotherapy machines. So this is the first machine that is functional there. This is a low-end machine. Can we think of a high-end machine and seek some inputs from physics people? Let's have a look at that. This machine is giving gamma rays. A linear accelerator gives me either photons or electrons, accelerated ones that have the capability of penetration. Penetration, and such penetrated particle deposits energy in the tumor bearing area and then escapes out. So it's a very sharp kind of knife that goes, kills bit of tumor but also goes outside, and while going out it can create another tumor in long run. So if I have a 90% cure rate, such 90 individuals, if they are living for 25 years, they might get another cancer in the region where I have given radiotherapy. So we are now looking at a newer technology. Can I have a slightly heavier particle? I accelerate that particle, and that accelerated particle goes to the tumor and deposits itself in the tumor. So there is no exit beam. So if there is no exit beam, there is no residual radiotherapy that goes to the normal, healthy surrounding tissue. And if that doesn't happen, then I have lesser cancers, greater long-term cure rates. If I can say that 80% are cured today, 20 years down the line, 80% will remain cured if a second cancer doesn't evolve in the exit beam arena. So there is a machine that comes with protons. Now here I need a thought process from your end. Protons are hydrogen. It's plain simple hydrogen that is accelerated. There are now thoughts that a slightly heavier atom, carbon, if I were to accelerate that, that can have a greater killer ability. I need to understand that that will need much greater energy. A 250 MeV is the energy required for proton, whereas carbon will require 450 MeV. And 450 MeV would mean huge amount of circular area where the acceleration. So the circle that produces carbon is approximately 90 feet wide. Imagine a dome that is 90 feet wide made of solid steel, that it will not allow this accelerated atom to escape, because if it escapes, it will kill anybody. So look at how these have evolved. Europe and USA have concentrated on hydrogen. So there are companies that manufacture protons. Japan, and there is one more company in China, they have mastered the technique of carbon. So they are selling carbon. They say that carbon is more effective. Probably carbon is effective in some deeper parts. Hydrogen is effective only in superficial parts. So do I buy a hydrogen producing machine as well as a carbon producing machine? The cost of hydrogen producing machine is 250 crores, whereas that of carbon producing machine is 850 crores. Imagine what is, when the cost of the machine that you saw just now, this cost of this machine is 2 crores. How many machines will come out of that? 250 crore, 850. And if I then were to buy an 850 crore worth machine as well as 250 crore worth machine, the whole spending of the country for health will go only in 2 machines. That's not the way we should be functioning. But where is the solution then? Is there a solution? Can we think of a versatile machine which can, with a switch, change 2 things? what is the source atom that is coming out? Can there be a tray wherein I replace the tray, the first tray has hydrogen. I want hydrogen now for the next 20 patients and I will accelerate hydrogen. So the energy required is 250 MeV, I use only 250 MeV. So I need variable energy, I need a variable source and a conducting system that will go to the patient and hit the tumor properly. So is there a possibility that I can have a single machine? Not 850 crore of one machine and 250 crore of second machine. Can we have a single machine? I would love to have inputs from physics people that can I just change a tray and switch the amount of energy that is served to this accelerator, a synchrotron. Is it possible that I can use only these two changes and produce at will either carbon or hydrogen? This kind of a thing will happen only if some of you start thinking in these lines and put your head into it. It's 20 years of hard work. Then there is possibility that we will have something. So there are lots of areas. I just gave you a few examples of what can be useful or what can't be useful. And majority of the things that we learn out of nature's design. So I keep on showing this slide, and this slide used to be not exactly the same slide, but multiple colored flowers being shown, that one of the Nobel laureates, Richard Feynman, would describe this, that there used to be, as a kid, father taking them into garden, and there will be lots of kids who would come. There were some fathers who would talk about the color of the flower or how many petals are there and so on and so forth. There are some fathers who were biologists, they would name the flower. So naming something, and then that child would give some horrible name which you never heard of. So rather than calling this simple Sadafuli, there will be some Vinka Tinka Chunka or some weird name coming out of it. But more importantly, what Feynman writes is that look at these flowers, that there are flowers of various colors. The purpose of those colors is to attract insects. Unless the insects come there can't be cross-pollination and reproduction or a continuation of the species. What does that mean? The conclusion is that the dog in your house doesn't have color vision. We all know that, but insects definitely have color vision. Nature will not create a flawed design wherein it creates 100 colored flowers and the insects don't have color vision. So look at it, that let there be a conclusion drawn out of nature's design, and you will have lots of solutions that come out of for treatment of cancers. Thank you very much.